Okay. Good evening, friends. We are back again. So today we have the renal replacement therapy part 2. Many of you have already would have attended our part 1. So we will be having the continuation as part 2. The same speaker, the Dr. Chacko from Bangalore. He will be dealing the second part also. I don't think Josa needs any introduction to this crowd, and we will discuss other topics like what we have left in the part 1. Over to Joe, sir.
Thanks very much, Anup. Welcome everyone to this second module of this renal replacement therapy webinar. We will start with a brief recap of the CRRT module that we went through last time for those of you who couldn't make it. So that's the key to renal replacement therapy, essentially. You have the filter, which may be of variable pore size depending on the modality that you choose. And you pass blood into the filter from the patient, and it filters through. After it filters out the molecules you want to be removed from the body. So that comes out as the effluent. This effluent obviously includes the molecules of renal failure, such as urea. It will also include water, and it will include electrolytes as well. Now this filtration occurs by a principle called convection, as we saw last time. Convection occurs when water moves out of the pores of the membrane, and as the water moves out, it'll carry solutes along with it. In other words, it is called solvent drag because the solvent drags the solutes along with it. So clearly, for solutes to come out, it depends on two things, just two things. First is the hydrostatic pressure within the filter. The higher the hydrostatic pressure, the more will be the filtration. And second will be the size of the pores within the filter. With a larger pore size, larger molecules will come out. And if it's a smaller pore size, obviously larger molecules will be left out. And then you have to replace the volume that you take out. As I mentioned, water comes out, a lot of water will come out. And depending on how much you want your patient to be in negative balance, you will need to replace an appropriate volume of fluid. And this is a fluid that contains electrolytes in the appropriate concentrations as appropriate for the normal physiological functions. You may also add dialysate. Now, when you add dialysate, you get clearance of molecules through a different mechanism. Dialysis results in diffusion of molecules from one side of the membrane to the other. Diffusion simply means the passage of molecules from a region of higher concentration to a region of lower concentration across a concentration gradient. That's how diffusion happens. So you have two mechanisms of clearance. Convection is entirely due to hydrostatic pressure and pore size. Dialysis happens, or exchange of molecules happens in dialysis through the mechanism of diffusion. So this is the basic principle of renal replacement therapy. And it's just a recap for those who couldn't attend the last module. One of the most important questions that we face every day in our practice in ICU is, when is a good time to start renal replacement therapy? This may sound simple, but it can be very intriguing at times. Now let's briefly look at what evidence do we have in terms of an appropriate time to commence renal replacement therapy. For this, there is no better classification than the KDIGO classification that was introduced several decades ago by the acute kidney injury group. And they divided acute kidney injury into 3 stages based on severity. Of course, this staging doesn't have anything to do with the decision to commence renal replacement therapy. However, it is a rough guidance to you as to how severe the acute kidney injury may be. Stage 1 is a creatinine rise of 1.5 to 1.9 milligrams, 1.5 to 1.5 times the basal creatinine level, or an increase of more than 0.3 milligrams per deciliter, and a urine output of less than 0.5 mils per kilogram per hour for more than 12 hours. So KDIGO essentially depends on the serum creatinine level as well as the urine output. Stage 2 is creatinine 2 to 2.9 times, or fallen urine output by less than 0.5 mils per kilogram per hour for more than 12 hours. And stage 3 is a rise of creatinine to more than 3 times the baseline, or increase to an absolute value of more than 4 milligrams per deciliter, or anuria for 12 hours, or fallen urine output to less than 0.3 mils per kilogram per hour for more than 24 hours. So that's the KDIGO classification which we use today to assess the severity of renal failure. But like I mentioned, this is just a guidance to you as to how severe the acute kidney injury may be, and it doesn't really give you any kind of guidance as to when is a good time to start renal replacement therapy. So what does the evidence actually tell us? There have been 3 major randomized controlled trials in the last few years that have asked this question as to when should you start dialysis. The ELINE study was a single center German study in which they randomized patients to receive early treatment, early renal replacement therapy within 8 hours of reaching KDIGO 2, or in the late arm within 12 hours of reaching KDIGO 3. KDIGO 2 is 1.5 to 1.9 times the creatinine, urine output less than 0.5 mils per kilogram per hour for a period of more than 12 hours. And KDIGO 3, as you know, is a creatinine rise by more than 3 times the baseline, or an absolute value of more than 4 milligrams per deciliter, or anuria for 12 hours, or urine output less than 0.3 mils per kilogram per hour for a period of more than 24 hours. So this is how they randomize their patients: early versus late, KDIGO 2 versus KDIGO 3. And what did they find? They came up with some very intriguing findings. First, they observed that the 90-day mortality, which was a primary endpoint in their study, was lower among patients who had early treatment versus those who had later treatment. However, the mortality benefit at 90 days seemed to stand alone because there was no difference in the mortality at 28 days or 60 days. So you would ask the question, if there was no difference in survival at 28 days and 60 days, how come they had a benefit at 90 days, which is a little difficult to understand. The second problem with this study was that 75% of the entire cohort of patients had evidence of fluid overload. Now, fluid overload is a major problem in renal failure. And even if no other indications exist, you may have to do renal replacement in your patients who are fluid overloaded. So 75% patients fluid overloaded obviously means they may have missed out on some of their patients who did in fact require early renal replacement therapy. And third, not the least, was the fact that the fragility index of the study was very low. Now, what is fragility index? Fragility index simply means how many patients in the intervention arm had to have a different outcome for the study to be non-significant. And in the ELINE study, if you took away 3 patients, or if 3 patients in one of the arms had a different outcome, the study would have become non-significant. So that is a very kind of not a very robust study, because if you just change the outcomes in 3 patients, the study would become null, or there will be no significance in the outcome. The second of the three studies was the AKI-KI study, in which they enrolled patients who were in KDIGO stage 3. All the patients were in KDIGO stage 3, and they randomized them to early renal replacement immediately after reaching KDIGO 3, and to the late therapy arm if they had some of the conventional markers of acute kidney injury, which we consider as absolutely mandatory to do renal replacement therapy. These criteria were potassium of more than 6 millimoles per liter. Of course, you would do dialysis in most of your patients with such a high level of potassium. A bond level of more than 112 milligrams per deciliter, and significant metabolic acidosis as evidenced by a pH of less than 7.15 and fluid overload. So that was the indication for late renal replacement therapy. Early was as soon as they reached KDIGO stage 3. And in this study, in contrast to the findings of the E-line study, they did not find any difference in the 60-day mortality between those who had early versus those who had later dialysis. So the AKI-KI study briefly did not show any difference among KDIGO stage 3 patients who underwent dialysis early versus those who underwent dialysis for more conventional indications. The third and the latest of these studies is the ideal ICU study, in which they use the rifle criteria, rifle F. As you know, rifle F corresponds to KDIGO 3, patients with 3 or more of creatinine, or an absolute value of more than 4 milligrams per deciliter, and urea for more than 12 hours, or oliguria as in less than 0.3 mils per kilogram per hour for more than 24 hours. So they chose rifle F, early, had dialysis or renal replacement therapy within 12 hours. In the late group, they waited for 48 hours after reaching, after reaching rifle F, they waited for 48 hours. And at the end of this waiting period, they still required dialysis, they would do it. Otherwise, they obviously wouldn't do it. And what did they find? Early versus late. There was no difference observed in the 90-day mortality, 58% versus 54%. And more interestingly, 38% of patients who were randomized to receive late renal replacement did not require renal replacement therapy at all. So it just goes to show that many of your patients in whom you rush in may not require dialysis, and they may be okay with conservative management, at least for the first several hours. So the sum of all these studies seems to suggest there is no rush to dialyze them too early. And if you ask me the question as to how do you decide, it is not only the KDIGO stage, as I mentioned previously. It depends on the baseline severity of illness of your patient, how many other organs are involved, and most importantly, it depends on the overall trajectory of the illness. If your patient is going downhill or the trend is downhill, yes, by all means, commence dialysis as early as you can, because later dialysis in such patients may carry very poor outcomes. However, if your patient is stabilized, or if the trajectory points an upward course, then you obviously can wait. That is a situation in which the vasopressor dose may be coming down. There may be some urine output that is coming through. So that simply means there is some light at the end of the tunnel, and you may not need to rush in with renal replacement therapy in such patients. So it's essentially a patient-centered decision that you will need to make by the bedside, and your clinical judgment will go a long way in making that decision. The next question: what dose do you use? Do you need to use a high dose renal replacement therapy, or would it be okay to use a more conservative or a lower dose of renal replacement therapy? So there are two studies that have looked at this, two benchmark studies which give us a lot of information as to what is a good dose. In the ATN study, they did either prolonged intermittent renal replacement therapy or hemodialysis 3 times per week versus 6 times per week, or they did CVV-HDF with a volume of 20 mils per kilogram per hour versus 35 mils per kilogram per hour. In the other study, the renal study, they used continuous therapy, continuous renal replacement therapy in all their patients at a dose of 25 versus 40 mils per kilogram per hour. And in both these studies, the answer seemed to be pretty much uniform. And it seemed to suggest that more aggressive or more high dose renal replacement therapy does not carry a survival benefit. So, if you're doing continuous therapies, roughly 25 mils per kilogram per hour would be a sufficient dose. This will work out in the average Indian patient to roughly about 1.5 to 2 liters per hour. So that would be sufficient in most of our patients. And many of our patients may not require more than 3 or 4 times per week of intermittent therapy, including slow, low efficiency dialysis, as the case may be. So that's a very important lesson to draw from this study, that high dose therapy may not be beneficial. In fact, people have done studies with high volume hemofiltration, trying to clear cytokines using this modality. They have also shown that cytokines do in fact clear with high volume hemofiltration. However, clearance of cytokines have not been shown to improve clinical outcomes. One of the most important questions that you need to ask in our patients in ICU is my patient volume overloaded? And if your patient is volume overloaded, you need to take out the extra volume fairly quickly. Otherwise, it might result in a longer duration of mechanical ventilation and all the associated complications, and it might affect mortality as well. ICU patients get volume overloaded for several reasons. You do a lot of initial intravenous fluid resuscitation, which will all accumulate over time. The nutrition that you use with nasogastric feeds mainly would also lead to volume accumulation. The medications that you administer, be it vasopressors, be it infusion with other agents, they will all add up to the total accumulated volume. And you very often have to use blood products as well, including red cells and other blood products. They all will add to the cumulative volume overload. So how do you assess by the bedside if your patient is volume overloaded? The central venous pressure is a time-honored method, but we all know today that it is far from perfect. In fact, it may be fairly useless in ICU patients as a marker of volume overload. But what you see on the screen is a very useful indicator, particularly in mechanically ventilated patients, the IVC diameter variation. In spontaneously breathing patients, the IVC diameter variability may not be very sensitive, because in many spontaneously breathing patients like you and me, especially if they are making vigorous spontaneous efforts, the IVC will collapse. That doesn't necessarily mean they're hypovolemic. But if you see an IVC that's dilated like this, without any respiratory variation in a mechanically ventilated patient without any spontaneous effort, it clearly shows that your patient is likely to be volume overloaded, and you may need to unload him, either with the use of diuretics if there is some renal function and if there is some urine output, or fluid removal by renal replacement therapy. The other most important method using ultrasonography is to look at the lung. The lung will give you a very good picture of how much volume it holds. Ultrasonography is much more sensitive than X-rays. X-rays lag behind considerably when it comes to assessment of the volume status and the volume of fluid within the lung. Stethoscopes are perhaps more sensitive than X-rays, but still, ultrasound is the most useful tool to assess volume status. Now, this is my own lung. I have placed the probe right below my clavicle here, and I'm looking at my pleura. That's my pleura. And You look for B lines essentially starting from the pleura. As you can see, there are no B lines there. I don't have pulmonary edema, thankfully. So that doesn't show any B lines. But look at this patient. He's actually a gentleman who came to us with breathlessness. He was ESRD, skipped a session or two of dialysis and became very breathless and was desaturating as he came to us. As you can see the pleura here. Unlike what you see here, you see numerous lines which start from the pleural line, radiate like laser beams, move with the pleural line from side to side, and reach the bottom of the screen. If you see something like this, it clearly shows that your patient is volume overloaded. Now, how about this image? If you see something like this image is an extreme form of volume overload. So much so that you cannot see individual B lines. The B lines are all merged together. It becomes a conglomerate of B lines, and that suggests extreme fluid overload. And this patient really requires fluid removal very urgently. So much about volume overload. The next question that you would ask, when do you stop? Stopping at a good time is also important. You need to understand that you obviously cannot continue with renal replacement therapy forever, and you need to decide as to when is an appropriate time to stop therapies. Now, what are the indications by the bedside as to when may be a good time to stop? As many of us have observed, the most promising sign of renal recovery is production of urine. If your patient has some urine coming, it means the kidney may have begun to improve and you can perhaps hold off dialysis. The use of diuretics may help you to take out more volume. In a patient who started passing some urine, if you use furosemide, say as an infusion of 10 or 20 milligrams per hour, which is normally what we do, you will get a much better urine output, and that will help take out volume, and you may be able to hold off dialysis temporarily, if not permanently. But does furosemide help in improving renal function? That's a different question altogether. It may not do from the evidence that we have so far, but it will definitely help in getting rid of extra volume from the body. Another very important question is, how do you preserve filter life in your patients, particularly with continuous therapies? You need to ensure that you run continuous therapies in a really continuous manner. There should be no interruption of treatment because the efficiency of continuous therapies depends entirely on its uninterrupted pattern of use. If you need to stop it, if the filter clots, for instance, in the middle of the night, suppose the filter clots, the dialysis will come to a standstill. You need to set up a new circuit. You need a person who's quite adept with doing this in the middle of the night. And then you need to get the fluid, you need to commence dialysis again. All this is not going to happen in an hour or two. It'll take several hours. And if you keep interrupting therapy time after time after time, CRRT becomes highly inefficient. In fact, several studies have shown that there may be a huge gap between the prescribed dose and the delivered dose because the filter clots. Thus, it is extremely important to use anticoagulation. Conventionally, we use normal heparin or conventional heparin, and the dose of heparin that you use depends on whether your patient has a coagulopathy or not at baseline. Many of our patients do have a coagulopathy at baseline, and you may need to cut down the dose of heparin appropriately. In a patient who is at low risk of coagulopathy, you normally start with a bolus dose of 3,000 to 5,000 units and run an infusion about 500 to 1,000 units per hour. And this dose will have to be appropriately tailored in patients who do have coagulopathy, whether be it at intermediate or high risk of coagulopathy. One of the main problems with unfractionated heparin is the fact that it can cause bleeding. And bleeding can be quite torrential, and it can happen to vital organs, including the brain, and that might result in a very adverse outcome in your patient. So, we have been exploring for other methods of anticoagulation over the years. And today, in many units, including ours, we prefer to use regional anticoagulation of the circuit using citrate anticoagulation. As you all know, the acid citrate dextrose or ACD solution is a solution that they use to anticoagulate blood products. So a similar method, a similar solution is used during continuous therapies as well. So the anticoagulation is purely regional. It just coagulates, it anticoagulates only the filter and the circuit. It does not pass the anticoagulant effect into the patient because, as we see later on, the anticoagulation effect is reversed by the use of calcium. And this citrate anticoagulant fluid doubles up as a buffer solution as well, because citrate gets converted to bicarbonate in a normally functioning liver. It is highly effective in preserving the filter and prolonging filter life. So your filter wouldn't go down in the middle of therapy and result in a long downtime. And of course, heparin, we all know, has the possibility of heparin-induced thrombocytopenia, which is not a problem with citrate anticoagulation. So in short, citrate anticoagulation results in a superior filter life, and it needs to be balanced with the possibility of liver failure. Of course, in liver failure, you shouldn't use citrate because the citrate will accumulate. The liver cannot convert the citrate to bicarbonate anymore. And of course, you need to ensure that there is adequate ionized calcium levels because citrate works by chelation of the calcium. Calcium, which is the key factor in the clotting mechanism, is antagonized by the chelation due to citrate. And so you need to administer the patient calcium to maintain appropriate calcium levels. So how do you do it in practice? So this is the CRRT circuit. This is the line, arterial line coming from out of the patient. And that passes on to the filter, as you see here. And you deliver the citrate solution pre-filter. The filter is anticoagulated as well as the circuit proximal to the filter is also anticoagulated using a solution called Resuscitate. That's a brand that is made by one of the companies. I'm not suggesting that you should use Resuscitate, but it's one of the solutions that's commonly used. It contains citrate 18 millimoles per liter. You must remember that each of these millimoles of citrate will get converted to 3 millimoles of bicarbonate in the liver. So essentially, you can use it as a replacement fluid as well. It doubles up as a buffer and a replacement fluid because it's a source of bicarbonate as well. It also contains sodium as well as chloride. So you have given Resuscitate solution pre-filter that results in chelation of the calcium. It anticoagulates the filter, and then you deliver dialysate here. The dialysate that you deliver will be to the filter, of course, in a countercurrent direction, as we discussed last time. The dialysate solution will contain, as you can see, a lower concentration of bicarbonate compared to the usual dialysate solutions. Why? Because, as I mentioned, the citrate gets converted to bicarbonate, and that will be sufficient in most patients. That's the reason why the bicarbonate, normal bicarbonate level in most of these solutions is 32 millimoles per liter. Compared to that, you have only 22 here, because part of the bicarbonate is made up by the conversion of citrate to bicarbonate in the liver. The rest of the concentration is pretty much similar. You have phosphate, sodium, potassium, magnesium, and chloride as well. So just to recap, you use a Resuscitate solution. The solution is used in proportion to the blood flow that you use. If you use 100 mils per minute of blood flow, which is the starting blood flow rate in most CRRT modalities, for every 100, you use 1 liter of Resuscitate. That's the replacement solution. It doubles up, as I mentioned, as replacement and as anticoagulation. And you use bifossil as a dialysate. The dialysate will be between 500 to 1 liter per hour. So Resuscitate approximately 1 liter per 100 mils per minute of blood flow, 1 liter per hour that is, and the dialysate will run at 500 to 1 liter per hour again. And then, of course, the most crucial aspect is to deliver calcium post-filter. So this whole part, this part of the filter itself, post-filter, it is anticoagulated. But you cannot obviously let the citrate run into the patient. So you have to antagonize it at this point. And that is done by administering calcium post-filter that will antagonize the citrate and overcome the anticoagulant effect as the blood returns to the patient. So this is a safe and effective method of anticoagulation of the circuit, and it has been shown to prolong filter life and associated with less bleeding complications compared to the use of heparin. So to summarize, we went through the basics of how the circuit works in CRRT, what is convective clearance, what is diffusive clearance, when to start therapy. Early therapy may not be beneficial, and more conventional indications may be appropriate, and even if you start therapy later, it may be appropriate. But one of the most important reasons is to remove volume, and if your patient is volume overloaded, you may have to commence early. Second question, when to stop? The earliest sign is some evidence of urine output, which you could perhaps augment with the use of furosemide or other loop diuretics. And if that happens, perhaps you can stop there and continue with the furosemide infusion, hoping that the kidney is on the way to recovery. And last but not the least, anticoagulation. Conventionally, we've been using normal heparin, unfractionated heparin, which may not be the best choice. We have the option of using citrate anticoagulation today, and it is safer, and it prolongs circuit life much longer than conventional heparin does. Less bleeding complications. Obviously, there is a little more cost associated with its use, but on the whole, I think if you get uninterrupted therapy, it may be worthwhile using citrate anticoagulation. So I'll stop here, Anup, and perhaps if there are any questions, we can take them now.
The the first question, I think we'll start from here only. The calcium dosage, how will we calculate? How much calcium has to
Yes,
be supplied?
the question is, how do you titrate the calcium when you're using citrate anticoagulation? There are two ways in which you can do. What many do is to measure the calcium level from pre-filter. You measure it pre-filter and you measure it from the patient. You measure it pre-filter and from the patient. The pre-filter level of calcium is maintained at about 0.25 to 0.4 millimoles per liter, which indicates that the calcium is adequate. That is pre-filter. The patient calcium, ionized calcium level, which you can do only with bedside blood gas analysis, because if you send it to the lab, it'll take a long time to get the reports. You need to do bedside. You start by doing 2 hourly, maintain the ionized calcium level of the patient within normal levels. And you do it, as I mentioned, start with 2 hourly, continue 4 hourly, and if it stabilizes, you don't need to do any more. So that is one method of doing it. And some people have also been using calcium as a direct proportion of the volume of the Resuscitate that is infused. In proportion to the volume that they infuse, they dilute it in saline and use it as a 1/3 of the Resuscitate infusion that you use. So you can use it that way as well, I suppose, but we haven't been doing that. We have been measuring patient levels. At least when you start, perhaps it is best to go by the patient ionized calcium levels and titrate calcium therapy accordingly. And as I mentioned, you need to measure pre-filter to make sure that it really has enough level, and also from the patient as well. You can give it post filter, you can give the calcium post filter into the circuit, or you can give it through a central line. That's the way it has been recommended to
Yeah.
use citrate and calcium.
Sir, other question is like the studies what you have mentioned, or the three major studies. Is it in the sick KI patients in the ICU, or can we extrapolate it to CKD patients also? That is one question.
No, it won't be applicable to patients. It's only for patients. All these studies have been done in critically ill patients in ICU, many of them with multi-organ dysfunction as well. So it doesn't really apply to patients with chronic kidney disease. It is only acute kidney injury in the setting of multi-organ failure.
So this citrate anticoagulation, can we try in SLED also?
I'm not sure. I think they have studied it in what's called SLED F, in which you use a replacement solution as well. So there is some clearance by hemofiltration and replacement with an appropriate replacement fluid as well. From my reading, I think it has been tried in SLED F, but I'm not sure about the actual data. There is no reason to believe that it will be less efficient with SLED compared to continuous therapies. It should be equally efficient, but titration of the dose of calcium and the titration of the dose of citrate and the titration of calcium to antagonize the citrate may vary depending on the blood flow, because the dose of the citrate depends entirely on the blood flow that you use. With SLED, the blood flows that you use is much higher than continuous therapies. Continuous therapies, you begin with 100 mils per minute. With SLED or intermittent hemodialysis, it may go up to 400 mils per minute. So depending on the flow, you will have to increase the volume of the citrate that you infuse. And of course, if it's a very high volume, you will need to take out that volume as well appropriately. So it depends totally on the blood flow rate as well as the dose of citrate that you infuse and how much volume you remove. So there are no real studies in this regard. Theoretically, it should be effective. In principle, citrate should work regardless of the mode of dialysis, but the fine-tuning of the dose and the reversal will need to be sorted out.
And sir, the dialysate also will have to be changed now. So the normal dialysate can be used with the citrate, like when we are using SLED.
Normal dialysate may give a little bit extra of bicarbonate because, as I mentioned, the conventional dialysate fluid contains 32 millimoles per liter of bicarbonate compared to the bifossil solution that we use with citrate, which is lower at 22 millimoles per liter. So it might actually give you a metabolic alkalosis with too much of bicarbonate. That's something you need to be wary of, and perhaps cut down on the dose of the dialysate fluid as well. So that is an area which hasn't really been investigated in detail. So the dialysate fluid will obviously have to be modified depending on whether you use citrate or not, because citrate gets converted to bicarbonate.
And some theoretical questions as well, sir. Like usually in intermittent hemodialysis, we use KT by V for urea reduction. So that can we utilize here in AKI patients also when the patient is on CRRT.
You can use it is a good or reasonable method of assessing the efficiency of clearance. I don't think people normally do it. If the system is working well and if you have uninterrupted therapy, you expect good clearance. But if you want to be doubly sure, of course, you can do KT by V maybe once or twice into dialysis and see how much clearance there is. But this may also vary with time. The filter efficiency, of course, will wane over time. And it is accepted that after several hours or after 1 or 2 days of therapy, the efficiency of the filter will come down. Normally, you can run it for roughly 72 hours without much problem. There would be adequate clearance even after 72 hours. And given that the citrate anticoagulation will give you a long life for the filter, you can continue it for a minimum duration of 72 hours without much problem. And of course, there are several other things that you can go by, including the acid-base level, the bond level as well. So all these levels will also give you an indication of the clearance without absolutely having to do KT by V from time to time.
So another question, I think that is related to bicar ICU trial. So the question is like, can we utilize or use bicarbonate in any like situation of AKI, and can we delay or even avoid renal replacement therapy?
I wouldn't suggest the use of bicarbonate in the hope that you can avoid doing dialysis, because most of the time what happens is sooner or later, it's only a matter of time before your patient goes into a crash situation and you may need to commence dialysis in a hurry, which is not the best way to do it. So, so don't do it with the intention of trying to avoid dialysis. But there are patients in whom the loss of bicarbonate may be the primary problem, like in patients with acute gastroenteritis or renal tubular acidosis. In these circumstances, they don't require dialysis. All you need to do is to replenish the lost bicarbonate, which can be easily achieved with a bicarbonate infusion. So correction of bicarbonate in that situation is okay. But in a patient with, say, sepsis, septic shock, acute kidney injury, if you try to avoid dialysis or delay dialysis with bicarbonate, it is only likely to run into more problems than solve them. That's my personal opinion. Although, as you mentioned, the BICAR study suggested that bicarbonate infusions may be of clinical benefit. This is not really the the general experience of people, and it's not really based on any kind of evidence as well, because acidosis, of course, is not the primary problem. There is an underlying problem that causes the acidosis, and just giving bicarbonate to reverse acidosis may not only not result in any help, it might actually paradoxically cause harm by several ways. I hope your mic is off.
Sorry, sir. Yeah. That question is, for taking out ultrafiltration, do we need dialysate plus filter or only the filter, as the mechanism is conviction? So the first of all, the mechanism is not conviction there. So I think, sir.
The question is, can you do just filtration without dialysis when you do CRRT? Am I
Oh, sir,
clear?
he's asking about only that scuff when we do, whether
Yes.
we need a like dialysate or a replacement.
No. When you're doing scuff, the only reason why you do scuff is to take out fluid. There is no other reason to do scuff. Your patient is volume overloaded due to whatever reason, and you do scuff purely with the intention of taking out fluid. It does not result in any clearance or very little clearance, because just filtration will not cause clearance. You need to add replacement to it to result in clearance, because you need to dilute what is left in the blood. Otherwise, there won't be any clearance. So if you do pure filtration without replacement, as you do in scuff, it will only take out volume. It will not give you any clearance. And of course, if you don't want any clearance, you need not use any replacement or dialysate. So just to remember, the only thing that scuff does is to take out volume and nothing else.
Then
I
the
hope, yeah,
disequilibrium syndrome, sir.
yes.
Can we have it with? They have asked about the disequilibrium management only. So can we
Okay.
have disequilibrium in an AKI situation when we are initiating CRRT also, and again the management of
With
disequilibrium?
CRRT, it is extremely uncommon to be almost negligible, I would say, because the way you do CRRT is in a very gentle manner. Clearance happens very, very slowly. The osmolality reduces very gradually. So any disequilibrium due to reduction in rapid osmolality, as you would see with hemodialysis, does not occur with CRRT. In fact, I doubt if there have been many case reports with disequilibrium syndrome with the use of CRRT. However, it is a common problem that you encounter with intermittent hemodialysis. So for all practical purposes, if you start your CRRT in a very gentle manner using low blood flow rates, using very slow blood flow rates to begin with, it is highly unlikely that it will result in disequilibrium syndrome.
I think, sir, we have covered almost all the topics, all the questions also we have covered.
Yes.
Uh, so, anything else we want to add, sir? Like,
No, I think we have covered
and
in
in
great
the
detail.
last question, in the COVID scenario, will the CRRT will be like more helpful? Like as there are more inflammatory mediators, your middle molecule removal with CRRT than the sled, because some people already started promoting like that.
Oh, I suppose you mean extracorporeal removal of cytokines with different devices that we have today.
That one part, sir, and again
Yes.
CRRT over sled,
Yes.
like as we are having a convective mode
Yeah.
also.
I don't think, given the evidence we have with cytokine clearance and outcomes, we should indulge in that kind of therapy in COVID patients. It is very clearly established, beyond any doubt at all, that you can clear cytokines with CRRT. It is highly efficient in clearing the middle molecules, which are the cytokines, including the interleukins, tumor necrosis factor alpha, and so on. And if you increase the volume of filtrate, if you increase it to a volume of 40 mils per kilogram per hour, you can very effectively clear cytokines. But unfortunately, this kind of cytokine clearance has not shown to have any benefit in terms of clinical outcomes over several decades of research. It has not seemed to touch any patient in any manner through removal of cytokines, through high volume hemofiltration. So, given that, I doubt very much if the cytokine response that you see in COVID 19 would change in any manner by purely removing these molecules through extracorporeal techniques, be it high volume hemofiltration or be it with the use of special devices that we know of, people are promoting today of different types. I hope that answer is clear. That is my personal opinion. There may be other points of view as well. I'm open to others' points of view as well, of course.
Sir, one last question. Like
Yes.
when we divide the replacement as pre and post filter, how to decide on that? How much post and pre filter, or only go with the pre or post filter, or the combination with
Yeah,
some calculations?
that's a
So
very
practically,
important
how we have to
question.
do that?
Yes. Uh, it really doesn't matter in terms of clearance. I think that should be very clear. Whether you deliver the dose pre-filter or post-filter will not affect the clearance. What really would affect the clearance is the total dose that you use. And whether you do diffusive clearance with dialysis or completely convective clearance with hemofiltration also does not matter, except in terms of the molecules that you clear, which, as I mentioned, may not really matter at all. So it doesn't really matter in terms of clearance, be it pre or post filter. But what really matters is filter life. If you deliver your if you deliver the dose pre-filter, if you give the replacement solution pre-filter, it will dilute the filter, and that might actually reduce the viscosity within the filter and prolong filter life. So you may be able to get away with a lower dose of anticoagulation, or perhaps even no anticoagulation if you deliver the fluid pre-filter. If you deliver all of it post-filter, there is a worry that the filter may get clotted. But in terms of clearance, delivering it post-filter may be more efficient. But all these things are only very finer aspects of it. The main thing is filter life. In fact, when we were in Australia, we used entirely hemofiltration, and all of it was pre-filter. And we used a dose of about 1.5 to 2 liters per hour, all of it pre-filter. And that actually prolonged the filter life. When I came to India later on, I realized that people mix pre and post in different proportions. And we use much more anticoagulation as well. So it depends on your circumstances and your patients. If your patient is at risk of bleeding, it makes sense to deliver most of it pre-filter and use less of anticoagulation. If there is no worry with bleeding, you can deliver more post-filter.
So thank you, friends, and thank you so much, Joe sir, for taking these two sessions on CRRT and renal replacement therapy, including the very basics. So thank you
Thanks,
so
Anu.
much, sir.
Thanks,
And again,
everyone.
we
We will
expect
meet
you in
next
this
time.
forum again with interesting topic. Sir has already agreed to take the reviews, sorry, the drug treatment reviews on COVID. So he'll be taking the reviews on hydroxychloroquine, lopinavir, ritonavir, plasma, and again our the new recovery trial, all those things we divided into short sessions, and along with the routine this thing we'll do, or if sir is comfortable, we'll take it as 1 or 2 days a days a session. Is it okay, sir?
Yeah, we can do a 2-day session as well because I think there is a lot of information. We can do it over 2 days as well. Yeah,
And it's every day, it's keep on changing now.
that's correct. It is very dynamic to say the least. Yes.
Okay, sir,
Okay,
thank you.
and thanks,
Thank you
thanks
so much,
everyone.
sir.
See you
Thank
next
you. Good
time.
night.
Thanks. Bye.